the examination is the same. You stand your patient for shoulder, you realize I stood him up. You can't set the patient down, but then you have to keep moving around the bed. I would say no, stand them up. Much easier for you, and at the end of the day, the patient might be happier too. With the spine, same thing, start from the back. Look from the back, inspect. So the patient has to be properly exposed. Short pants is perfect, a little bit shorter if possible to see the muscle bulk of the thighs, which is very important as well. You'll understand why just now. So looking from here, the spine again is a three-dimensional thing. So you must look from at least two different places. So from the back, you're looking for curves in the coronal plane, because you're looking at 90 degrees in coronal plane here, right? So coronal curves is what people talk about scoliosis. Yeah, but what we will talk about is if there's asymmetry in the coronal plane. Scoliosis is kind of defined by the curve being more than 20 degrees. Yeah, otherwise it's spinal asymmetry. So you just talk about if there's a curve in the coronal plane. Then you come from here and you look at the normal curvature. This should be lordotic, kyphotic, lordotic, kyphotic. Cervical, thoracic, lumbar, sacral. That's the inspection. Right? If you want to go even further, with respect to inspection, you can drop a plumb line. Plumb line is basically a line with a little weight at the bottom, so it drops straight and it works with gravity. Put it over the vertebral prominence, let it drop, and it should line up straight with the spine all the way down to the coccyx. If any spinous process is away from the center, there is some degree of curvature. Now, if you want to test the movement of the spine, so we just looked, feel, just palpate all the spinal processes all the way down, each one, all the way down. Movement is kind of important for the spine, no? That is what we're there for. Remember, the curves is all about forming like a little spring action. So when you land, it can take the force. Yeah, so that's why not straight. Straight is not good in this case. So there's something called Schrober's test. I think it's Schrober's. S-C-H-R-O-E. The O have the little two dots on top of it. B-E-R''S. Yeah. What it does, it looks at the flexibility of the lumbar spine. The most important is in flexion. Flexion is this way. So what you do, the sacral dimples, which are right there actually, you can see them right there, they form the posterior superior iliac spines. So next time you see somebody in a bikini and you see the dimples, all I want you to think is posterior superior iliac spines. Nothing else. Right? So they should be even. If they're not even, either the limb lengths are off or the pelvic obliquity is off. They should be, and they should form a straight line. So you draw a straight line between them, and you can actually draw an impatient when you have them. And in the midline, draw a line that's about 10 centimeters long. Then, ask the patient to bend forward. And when your patient bends forward, touch your toes. You should have an increase in the line to at least 15 centimeters. Just look what happens to the tips of my fingers when he stands up. Up now? I didn't move them, right? So that's Schrober's test. At least 5 centimeters lengthening is considered normal. You can test lateral bending, extension, rotation, but it doesn't give you as much information as this simple test. So the rest of them are as important. How do you test lateral bending? Measure the tip of the finger from the floor. Give you an idea how far I go. Extension, same thing. Yeah? Not as important. Same thing with rotation. How far the shoulders could go, but you have to keep the pelvis square. But not as important. Again, Schrober's test is what you need to do. Right? The other thing is when he bends forward, what you look for is asymmetry in the paraspinal region. Paraspinal is, so just tilt forward a little bit for me now. You gotta go all the way down, right? So look here. When he bends all the way forward, if one spot is more prominent, just this one. If one spot is more prominent, it means that there's a twist in the spine. You don't need to do this, I just showing you. Right? On the real day, you'll be bent forward like that, and you just comment on asymmetry. The scoliosis does have a rotational component. Yes? Yeah. And that's it for the spine, you know. You know what's the rest of the exam? A lower limb exam. You know why? The importance of the spinal cord, aside from support, is kind of houses the spinal cord. The spinal column, sorry, houses the spinal cord. So what you want to do, if you examine the spine, is examine the lower limbs. So you now need to do a full neurological exam. Tone, power, reflexes, sensation, and what else? That's it? Yeah, that's it. And then you must do a diary. And that completes your spine exam. Why do you need to do a diary? Why do you need to do a diary?
I think it's our
What? So you're looking at for the lower limb. Once it tests in the spine, lower limb, you're looking at the lumbosacral plexus. So from L1, L2, which flexes the hip, 3, 4 extends the knees, right? 4, 5 dorsiflexes the ankle, and S1 gives you the ability to go on tiptoes. When you reach S2, 3, 4, it actually supplies the sphincter. So if you don't do the DRE, you don't test 2, 3, 4. And in this case, is another time when you can say, if you don't put your finger in it, you put your foot in it. I think I completely misunderstand. It means if you don't do a DRE, you're basically stepping in shit. You're putting yourself in rubbish. Take all your minds out the gutter. I don't know what is the watching. So, impossible. So, the next example is the knee exam. And this comes before the exam, by the way. So we just show this forward. A shoulder and knee will come forward. Three.
I said like the
Next osteoid might get shoulder.
This one?
Will it have continuous? Yeah, but it might probably get shoulder.
Yeah, 3 or 2.
You could have like 4 exams, you could get 5, 6. So,
It could be history.
we know. Hey, it's time.
No, which one? No, which one? Which one?
I don't know.
5 past 2. 5 past 2.
I'm just telling you, don't shoulder. So, we're going to do the knee exam, right? So, when you're doing the knee, nothing changes. Look, feel, move, special maneuvers. One thing does change. Instead of having the patient just standing, you're going to have to do all the different maneuvers for knee. So let's give Anthony some space. Anthony, I just want you to stand across there. So we're going to start with looking. And what's important with looking, you have the patient stand normally. And if they're jittery and they're not sure, just tell them walk, stop, and that is the normal position. Quite simple. So what you want to look at is just simply the alignment of the lower limbs. If there's any asymmetry at all, you comment on it. With respect to inspection, nothing changes. You're looking at muscle bulk, you're looking at fasciculations, you're looking at scars. The knee joint extends all the way to the back, so guess where you have to go? To the back and look at the popliteal fossa. You must. Yeah? With respect to the patella, you could comment on where the patella pointing. Because majority of the time the patella actually is a little bit externally rotated, not completely forward. It can be forward, but the feet, if you could draw a line straight down the middle, are usually a little bit externally rotated, most people. Yeah? Some people will be straight, not come on. They'll be about 10 to 15 degrees out. And that's normal. Same. No change. No change. Yeah? Now, that's with respect to this inspection. What can you see that's abnormal? Why is this so important? Aside from scars, wasting, fasciculations, you could look at how the limb is lined up. If the knee goes out like that, what's that for? Rickets. Varus or valgus? Varus or valgus. It speaks about or speaks to where the limb is with respect to the midline. Valgus goes away from the midline. So this will be a valgus knee. This would be a varus knee. We call it knock knee and bow foot or bow leg. Yeah? Valgus goes away, the distal part of the limb. So you could have genu valgum, you could have coxa valgum, goes away. You could have calcaneo valgum, calcaneus goes away. You could have cubitus valgum, cubitus, the elbow goes away. We just have to put it together. That's important because it has to do with the axis of the lower limb and how the patient bears weight, how forces are transmitted. All important. Normal patient, 5 to 7 degrees of valgus. Normal. Normal. So you will comment on that or if there's asymmetry. Right? Next thing you're going to do is let's ask the patient to walk. So Anthony, I just want to take a couple of steps towards me, turn and just walk the other direction. So we're just looking at his gait. We're looking to see if there's any abnormality at all. Gait seems to be normal. Abnormalities that you can see, what is an antalgic gait? If I had pain in my right leg, would I want to put more weight on it or less? Yes. Yeah, so when I walk in, I will do this. The time spent on the limb, on the right limb, will be less. That kind of defines an antalgic gait. You spend less time on that limb. The phases of gait you don't need to know yet. But you just need to recognize that there's an abnormality. If the patient walks and they do this, every time they walk, they get that. That's a valgus thrust, or varus thrust, sorry. Yeah, and if the ligaments are torn, patients can actually walk like that, and then he gives out every time they step. That's the way to live it, what could happen. So you must be able to comment on these things. So we've stood the patient, we've walked the patient. What we're going to do now is sit the patient down. So we're going to ask him to have a seat on the bed. If you want. Anything sexy? Nobody comes in. Right? So look, what do you think you're going to feel for on the knee? Ligaments. What else? We talk about feeling on the orthopedic exam all the time. We always feel for. The only prominence is. Yeah, so let's look for the bony. So what we can do is stick the look, feel, move, right? What we can look at is just look at the symmetry. Look at the quadriceps again. Of course, it'll be a little bit deformed because he's sitting and pressing down on it, pressing up. So if there's something there I can mention, otherwise don't bother about it. We can look, just look for symmetry. And if there's nothing wrong, then we ask them to do something. You can ask them to extend the knee or straighten the leg, whichever way you want to tell the patient to do it. So you're going to look for something, and you're going to look at the movement of the patella. Straighten your leg slowly for me. And the patella just comes up and sits nicely in the trochlear groove, where it's supposed to be. If you had instability, the patella would have come up and slipped across like that. It's called a J sign. Yeah? Or inverted J sign. It comes up and slips across because it's unstable. And the reasons are beyond you. You just need to know that it could happen. Right? What you could do as well, knee back down, is feel. Straighten your knee from here again. And what am I feeling for? Crepitus. Yeah, you're crepitus. Congratulations. So crepitus is kind of a change, something that suggests degenerative change. So it's one of the things that can get with osteoarthritis. What does it mean? The cartilage surface is wearing away. Yeah, so you're now getting bone rubbing on cartilage or bone rubbing on bone. And that gives you that crepitus feeling. Right? And that's the basic things that we can get from the part of sitting. When we feel, you can feel the entire extensor mechanism. So you can palpate the quadriceps tendon, you can palpate the patella tendon, and the tibial tubercle. We can also palpate the collateral ligaments. But what we do is we find where they start. Yeah? So this is here. Lateral gate, the lateral condyle, medial condyle. Very prominent. So the lateral condyle is where the lateral collateral ligament starts and comes down and goes down to the fibular head. Look where the fibular head is. Look how posterior. It's not, yeah, it's not right here. It's quite posterior. Yeah? And you can palpate the fibular head. Up down. On the medial side, medial of the condyle, come down and all the way down to the tibia. Right? And you palpate all that, and of course you're looking for pain on the patient, so you'll be doing this from the front, whichever leg you need to. And that's basic palpation of all the different things. What you can do as well, while you're here, is you can palpate the joint line. But I don't want to do that here, I want to do that when we lie down. So when we lie the patient down, with him lying down, now we can properly assess the quadriceps mass. And we want to talk about symmetry. Is any one of them wasted? Why? Because the extensor mechanism from ASIS, quadriceps tendon, patella tendon, tibial tubercle, that entire mechanism is very important for gait and walking. Yeah, we're walking and gait. Yeah, but it's very important for gait. So if something is wrong with it, the patient is obviously going to have problems. So we're going to comment on that. You could even measure it. How? Take a distance from the tibial tubercle up, so it's fixed. Patella could shift. Tibial tubercle not so much. measure about 15 centimeters above, and then you check your diameter here. 15 centimeters above, measure diameter here, and compare them. Bony prominences are your friend. Yeah? What we could also look for is if there is an effusion in the joint. You see how nice and clear you can see the edges of the patella here? If there's an effusion, this balloons out. So what you can actually do is tap the patella, and you'll actually feel it hitting the bone behind. And you'll actually get that sensation of bone touching bone. If the effusion is more, you can actually put your hands here. This is the suprapatellar pouch. This is actually an extension of the joint all the way up here. Press down here and push the patella down. And you'll feel that the plunk as it hits. Yeah? If the effusion is very small, just squeeze here. Squeeze all the fluid out. And then as you look, press down and it'll balloon out. So you can milk the effusion down. So there's a milk test or the bulge test. There's patella tap and then there's patella bulge. You just pick one of them. Yeah? Quite simple. And you're looking for effusion. Next we're going to do is ask the patient to bend your knees to me, please. And we're coming up to 90 degrees. Press your feet out back. Right here. And come, just put relaxed. So, around 90 degrees, and you have your knees relaxed. What we're going to look for here? We have to look for something called a posterior sag. A posterior sag comes about because there's something in the knee that's not doing its job. So the tibia falls backward on the femur. We need two big ligaments. We talked about the collateral ligaments just now, right? We're going to test them just now. We were just palpating for them. We have two big ligaments on the inside that kind of cross like that.
ACL.
Two big ligaments. That's one.
That's ACL and MCL.
ACL and
MCL.
PCL. So anterior and posterior cruciates. Yeah? So they cross out inside the joint. They come from between the condyles and the femur, inside the joint. One goes anterior, the ACL. One goes posterior, the PCL. Wherever they go on tibia, that's what movement they stop with respect to the tibia. So the ACL stops the tibia from shifting forward. The PCL stops it from shifting back. Yes? Simple? Yes? So, if he's relaxed and the PCL is ruptured, what happens to the tibia? It's just going to fall back and you get a sag sign. Yeah? So when you look from here at the tibial tubercles, one is going to be behind the other, and the patella and the patella tendon are going to appear more prominent because that has shifted back. That's because PCL is gone. If you want to test that and really see, so let's say he had a sag sign, and we wanted to test and see if there's really a sag sign, it was just his anatomy. We put our hands on his feet and tell him, I want you to extend your feet gently as if picking a ball. And as he pushes out, we feel quadriceps are contracting. The quadriceps come and attach on the tibial tubercle. So what do? If they tense, they're going to pull the tibial tubercle forward and it shifts them. And it settles back where it's supposed to be. And that's called the quads active test. Because the quadriceps are active during the test. Simple. Yeah? We've just tested for PCL. Done. The anterior, what we remember, I told you about the meniscal injury. You know what the menisci are, right? We know what the menisci are? Meniscus, medial meniscus, lateral meniscus. Am I supposed to know? I'll do MBJ.
We reach
Reach near. Like this story. So the menisci are like two shock absorbing pads. One for each femoral condyle, on top each tibia, the condyles of each tibia, the tibia plateau. Yeah? So there's medial and lateral. Medial, lateral. So the joint line, if you feel right here and you come up, your fingers will slip into the joint line right here. Palpating joint line is one of the most sensitive tests for meniscal pathology. So you just palpate the joint line. That's it. Palpate the joint line on both sides and ask the patient if he's having pain. Anterior to posterior. Not both at the same time. You'll have to do one at a time. Yeah, to look for pathology. That's it. That's one major test for meniscus. The anterior draw test was described at 90 degrees. Anterior draw. Obviously, there's a posterior draw, but it's kind of nonsensical if you really think about it. But you could use it. The anterior draw means you're pulling the tibia forward on the femur. And why would that happen? Why would you be able to do that? The ACL is ruptured. So it's no longer stopping the tibia from coming forward. So if you come from here, some people would sit on the foot so that it doesn't move forward, so they could use both hands here and pull it forward. And you're going to rock it. Right? And you're looking, so use your thumbs by tibial tubercle and rock it forward and look for any shift in the joint. Yeah? Same thing on this side, you check for both hands. Or you could use one hand to check for it, shift forward like that. Yeah? Kind of crude. So somebody was like, I don't think that's the best test. So, because they use secondary restraints, there are other ligaments that kind of help the tibia from moving forward as well. There are other ligaments except the ACL. So let's isolate the ACL. You see this isolating coming up off the right. How do we isolate the ACL? Well, let's put flat for me. Just look at this foot. We're going to bring it out to about 20-30 degrees flexion. Support the leg, hold it there, and rock it forward and back. He actually has a little bit of laxity. Little bit. So, does he have an ACL injury? We check the other side. Same thing. So that's his normal anatomy. That's Lachman's test. LACHMAN''S. 20 to 30 degrees flexion, and it was if you do the same draw test. And that test to see if the ACL is gone. Remember, if your PCL is injured and the leg falls back, if you pull forward, are they going to shift forward to you? Yeah, so if you have a PCL injury, it could give you a false positive test for the ACL. So you need to make sure that it sits, the tibia is sitting properly in the position before you try pulling it forward. Yes? Keep that in mind. We could test now. We just test for the 2 cruciates. Now we test for the 2 collaterals. So the patient is an extension. Make sure the patella is pointing straight forward. If it's not, it's going to happen every time you do it. So patella points straight forward. Hand on the outside, pull here. So testing medial collateral ligament. Lateral collateral, test here. In extension, and then in 20 degrees flexion again. So he has some movement there. See it? You actually see it, right? So is there a lateral here? Well, let's see. No, there's no. That's his no. Right? Little shift stops all of a sudden hard. That's no. So we tested cruciates, we've tested collaterals, we've tested meniscus. There's only one more thing to test. And it's something that relatively new, when I say relatively new, is a few years, that they've come about and realized is very important for the rotational stability of the knee. All these fancy football players who too fast, too strong and too big, when they put stress on the knee, they rip the ACLs out in football all the time. So they get repairs, and they started repairing the ACLs or reconstructing the ACL. Repairing is different, repairing means they stitch together. They reconstruct it, meaning that they take tissue from somewhere else on the patient body or tissue from somewhere else. So autograft or allograft, and they put it back in the patient and make back a ligament for them. So they reconstruct the ligament. And they realize after they reconstruct the ligament and they rehabilitate the patient, they were still tearing back out. They were rupturing. They realized something was wrong, they were missing something. And then they came across this they were going to put separators. There's a group of structures that form something called the posterolateral corner. The posterolateral corner is exactly as this, it's posterior and lateral. And there's like 16 things or 14 things that make up the posterolateral corner. Plenty things. But you just need to know that it can cause rotational instability. And the way to test for it is real simple. Just lie on the tummy for me. So what you're going to do, at 90 degrees, yes, externally rotate. And you're looking for symmetry. If there's asymmetry here, whichever one goes out more, the posterolateral corner and the PCL, the posterior cruciate ligament, go to go. If you want to isolate the posterolateral corner, come into 30 degrees and externally rotate. Remember at 30 degrees PCL is sitting nicely, so PCL is working. So you're isolating here now, posterolateral corner. So if one goes out more than the other, posterolateral corner is going there. And this is called the dial test, because the feet acts as dials, showing you how far they can go. And that's any test. That's it. The exam becomes simple. Yeah? The beginning is look, feel your palpate your bony prominences. When you put the patient to lie down, you're going to test everything within the knee. You're testing the cruciate ligaments, the posterior cruciate, you're looking for a SAG sign. The anterior cruciate, you're doing your Lachman's or your anterior draw. I prefer Lachman's. You do your Lachman's because it's much more sensitive. The menisci, you palpate the joint line. The collaterals, you do your varus and valgus stress, extended and 20-degree flexion. Remember the anatomy and then you put the test. If for some reason it's difficult to palpate the joint line, you can do this test. Come. And this whole test, because when you're reading your apples, you're going to come across McMurray's or the grind test or something like that, right? Which kind of barbaric. Because basically putting the patient down, pressing them on the leg and squeezing them down like that. So what we do is you make the patient do it for themselves. So we ask the patient to face us, bend one knee up. So we're going to be testing the right knee for him. Bend a little bit here. And just twist like this for me. Not so much. Right? If the patient can't even do that, it's very likely that they have a meniscal injury. So if they get intense pain with the rotation, it's very likely to have a meniscal injury. It's called the Thessaly's test. Thessaly apostrophe S. Thessaly. Thessaly apostrophe S. Any questions? Questions, comments, criticisms? You can watch it still, teacher? No.
I've never learned so much in this skills.
Anybody else need to sign this one? Anybody sign? Okay. Any questions?
No.